Hi and welcome to this revision video on acute myeloid leukemia aimed at haematology registrars revising for their FRCPATH exams. My name's Harini and I'm currently a registrar in Nottingham. What the video will cover are the clinical features, the workup needed, how AML is monitored, and first-line treatment. So acute myeloid leukemia is a heterogeneous group of aggressive blood cancers that arise from clonal expansion of malignant hematopoietic precursor cells in the bone marrow. The leukemic cells interfere with the normal marrow functions, leading to pancytopenia, infection, and bleeding. AML is the second most common category of leukemia in adults, but it's relatively rare with approximately 1% of adult cancers. The median age of diagnosis is approximately 68, and the incidence increases with age, with a modest predominance in men. It has been associated with environmental factors like chemicals, radiation, tobacco, previous chemotherapy, and retroviruses. In some patients, the development of AML is on a spectrum and is preceded by clonal hematopoiesis, which may manifest as myelodysplastic syndrome, myeloproliferative neoplasms, paroxysmal nocturnal hemoglobinuria, aplastic anemia, or clonal hematopoiesis of indeterminate prognosis (CHIP), or clonal cytopenia of unknown significance (CCUS). In rarer cases, AML in adults is associated with inherited genetic abnormalities, which include mutations or loss of tumor suppressor or DNA damage repair genes. So, trisomy 21, Fanconi's anemia, Li-Fraumeni syndrome, Bloom syndrome, and familial mutations of CBPA, DDX41 or 1X1. So patients with AML generally present with symptoms related to pancytopenia, so anemia, neutropenia, and thrombocytopenia. So they may present with weakness or tiredness. Bone pain is infrequent, but some individuals do describe sternal discomfort in the long bones. Younger patients may present with recurrent infections, and older patients may present with chest pain, unable to deal with the anemia. Leukemic cutis is a skin manifestation and it's common with the monocytic subtype. Gingival hypertrophy is also common in the monocytic subtypes. So the workup needed is a mixture of diagnostic tests, the blood films, flow cytometry, aspirate morphology, and cytogenetics. Full blood count is needed to determine leukostasis and the degree of pancytopenia to correct blood products. When the blast count is high, leukostasis can lead to issues with hypoxia and central nervous system issues. So these patients will need leukapheresis or to be correctly cytoreduced with hydroxycarbamide. Clotting is especially important in APL, which has low fibrinogen and a tendency for DIC. So cryoprecipitate is needed for reversing fibrinogen in low fibrinogen levels. So you give cryoprecipitate to maintain a level above 1.5. Tumor lysis can occur spontaneously, especially with high white cell counts. So there is a low threshold for using respiricase for uric acid management and hyperkalemia management. On the peripheral blood film, you will see myeloblasts, which are immature cells with large nuclei and prominent nucleoli with variable amount of cytoplasm. The nuclear to cytoplasmic ratio and morphology vary depending on the maturity of the cell. Our rods, which are pathognomic of myeloblasts, occur only in AML. On the bone marrow aspirate, more than 20% blast count in the bone marrow is AML, period. But if you have a translocation of 821 in version 16, they are core binding factor leukemias and are AML regardless of the blast count. Flow cytometry is important at differentiating AML from ALL or mixed lineage AML. Having a few myeloid markers such as CD33, CD117, MPO is more in keeping with AML, but having CD3 or CD10 markers may indicate a mixed lineage picture. So FISH, fluorescent in situ hybridization, looks at chromosomal changes. It involves the application of a fluorescent DNA probe specific to the gene or genetic regions of interest that highlight the abnormalities involved in these regions. It can be turned around in about 24 hours. So in our lab in-house, we can do in version 16, 821 core binding factor leukemias, 15, 17 translocation, for PML-RARA fusion gene for APML, as well as deletion 5, deletion 7, which are normally seen in MDS-related AML. You can also do FISH for inversion 3, which is MECOM gene, or 1713 translocation TP53 mutation. Molecular PCR are used to look for proteins of NPM1, FLT3 IDT, TKD, IDH1, and IDH2 mutations. It's important for a quick turnaround with these within 24 hours to determine whether the patient's eligible for targetable treatment. So a key change in the WHO classification in 2022 is the separation of AML with defined genetic abnormalities from AML defined by differentiation. The WHO criteria also eliminated the 20% blast requirement for AML if you have defining genetic abnormalities, such as AML with 821 translocation, RUNX1, RUNX1T1, AML inversion 16, so they're both core binding factor leukemias, APML, AML with KMT2A rearrangement, 69DEC NUP214 fusion genes, MECOM arrangement, NUP98 rearrangement, and APML with mutated NPM1 or biallelic mutations of CEBPA. AML with BCR-ABL fusion and AML with CEBPA mutation still have the 20% cutoff, however. Specific gene mutations are also related with myelodysplasia, and having those mutations will give you the terminology AML myelodysplasia related. And these include the mutations of SRSF2, SF3B1, 5q deletion, 7q deletion, 11q deletion, 12p, 17p deletion, and so on. So measurable residual disease, MRD monitoring, has a purpose to monitor response to treatment. MRD positivity is bad and there's a high rate of relapse. An MRD negative patient has a better chance of cure. The NPM1 gene is the most validated, where studies show that patients who are MRD negative after 2 cycles have a 70% chance of being cured without relapse at 5 years. If it is positive, then there's a 75% chance of relapse. So you can use RT-PCR to monitor NPM1, inversion 16, PML-RARA, BCR-ABL, NUP98, and KMT2A. The RT-PCR samples on peripheral blood and bone marrow aspirate are sent to Guy's Hospital, which is a central lab in London. It's normally done at diagnosis and then repeated after every cycle, 3 monthly for 2 years. If the transcripts are rising, then it should be repeated immediately. Molecular relapse is confirmed if 2 consecutive positive results. The NPM1 gene is located on chromosome 5 and is the gatekeeper of AML, so it's not found in clonal hematopoiesis. So MRD negativity in the peripheral blood after 2 cycles is key. So AML defined by differentiation is shown below. AML with PML-RARA fusion show hypergranular promyelocytes and bilobed nucleuses. AML with the RUNX1 fusion 821 translocation show differentiation to mature neutrophils. Neutropenia is uncommon and the blasts have an identified nucleus, often with hour rods. Core binding factor leukemias inversion 16 usually has an appearance of acute myelomonocytic leukemia with eosinophilia. And the 6-9 translocation is also almost always associated with a FLT3 mutation in basophilia. Inversion 3 is an adverse risk caused by the overexpression of the oncogene. AML with a MECOM rearrangement. Inversion 3 may have dysplastic megakaryocytes. AML with KMT2A rearrangement 911. MMRT3 KMT2A have an appearance of acute monoblastic leukemia. So the ELN risk criteria is used to group certain cytogenetics into favorable risk, intermediate, and adverse risk. And this is used to determine treatment choices. Favorable risk cytogenetics include 821 inversion, RUNX1 inversion 16, NPM1 without FLT3, and 2 mutations of the CEBPA gene. Generally, in this favorable risk group, you try and cure them with chemotherapy alone. So you could give them 2 cycles of DA, followed by high-dose cytarabine consolidation. Whereas in adverse risks patients, allogeneic stem cell transplant would be needed after first remission. Mutated RUNX1, ASXL1, TP53. This is more secondary biology and therefore needs to be treated more intensely. And patients with adverse features will need an autologous stem cell transplant. Extramedullary leukemia, so leukemia presenting outside the bloodstream, can manifest as symptoms like leukemia cutis. If the patient is fit, then you would treat them with an intensive regimen with something like DA, go, daunorubicin and cytarabine and gemtuzumab. If the patient was less fit, then you would consider venasa or a targeted inhibitor. So it's still important for these patients to have molecular PCRs done for NPM1, RDH and FLT3 to sequence and stratify them. Transient leukemia of Down syndrome is a condition that originates from abnormal megakaryocyte precursors and occurs in 5 to 30% of neonates with Down syndrome. It's defined by the presence of a mutation of GATA1 combined with an increased blast count. The BSH recommends considering transient leukemia of Down syndrome if the blast count is more than 10%. More than 20% is very specific for TLDS. Neonates with 10% blasts and no other worrying features may be observed. Investigating it involves sending the peripheral blood to look for GATA1 mutations. In some cases, the condition will spontaneously resolve, but in 20% of patients, it can develop to AML within 4 years. High-risk patients will require treatment, such as patients who have a high white cell count, who have liver disease with high transaminase levels, a white cell count of more than 50, bilirubin of more than 83, ascites or massive hepatomegaly, pleural and pericardial effusions, or renal failure or DIC. The condition generally. So APML is one of those hematological emergencies that you need to seriously be worried about. It has an extremely high curative rate, but also a high mortality of 10%. The important things would be to look at the peripheral smear and suspect it if there is pancytopenia with extremely low platelets. It's common in the hypergranular variant with lots of owl rods, which is thought to provoke the coagulation cascade and cause DIC. Generally, the patients are CD33 positive and negative for CD34 and HLA-DR on flow cytometry. Starting ATRA immediately will start the differentiation process of the hematological cells. There is, however, an early mortality rate due to hemorrhage from coagulopathy. The SANS criteria is used to determine whether a patient is high risk or low risk. Low risk patients with white cells of less than 10 and platelets of more than 40 can have ATRA and arsenic. But treatment with high risk disease involves white cells of more than 10. You could think of using induction with ATRA and idarubicin. So in low intermediate risk treatment, arsenic and ATRA induction with 4 cycles of consolidation has a more than 90% cure rate for high-risk patients with white cells of more than 10. Gemtuzumab is also effective for high-risk APL to be used as a one-off. Differentiation syndrome occurs in about up to 25% of patients with ATRA or arsenic as cells differentiate. The onset is between 2 to 21 days because as myeloid cells develop, there's the production of inflammatory cytokines which can manifest as shortness of breath, fever. Treatment is steroids with dexamethasone, 10 milligrams twice a day for 3 days until the fever and shortness of breath or hypoxia have resolved. You could think about holding the ATRA if the symptoms are severe. APL monitoring includes doing a PCR in the peripheral blood and the bone marrow for PML-RARA. If the patient is positive for PCR, then you need to treat for relapse with ATRA and arsenic. The new WHO 22 classification gets rid of the label therapy-related AML, and it's now a tagline post-cytotoxic therapy that you can use on any of the other AML diagnoses. For example, AML with KMT2A rearrangement post-cytotoxic therapy. Patients would have had chemo or radiotherapy 5 to 10 years ago. Alkylating agents can cause -5, -7, -17 deletions. Topoisomerase inhibitors can cause MLL, KMT2A rearrangements. The most common induction regimen for AML includes cytarabine and an anthracycline drug such as daunorubicin or idarubicin. This is called the 7-3 regimen induction. On days 1, 4, and 7, you can give gemtuzumab, which is an anti-CD33 antibody. If the patient has come back FLT3 positive, then you will stop the gemtuzumab and switch them to midostaurin. That should start on day 8 until day 21. If there's a delay in obtaining FLT3 mutation status, this could be started on day 11 and continued for 14 days. Patients who remain in remission after completion of consolidation therapy continue on to maintenance. Gemtuzumab mustn't be started if the white cell count's more than 30 because of a high risk of tumor lysis and hypersensitivity reactions. Hydroxycarbamide, 40 to 60 milligrams per kilogram per day, can be used to reduce the white cell count before commencing gemtuzumab. And patients are only eligible to receive gemtuzumab if their liver functions are within range, due to the risk of veno-occlusive disease. Patients with poor heart function may not be able to be treated with anthracycline, so could be treated with another chemo drug such as fludarabine or etoposide. So generally, induction regimens are DA, and the aim would be to get the patient into remission as quickly as possible. For patients with favourable risk, this will involve at least 2 cycles of DA, and once in remission, 2 cycles of high-dose cytarabine for consolidation. For patients who are adverse risk, as soon as they achieve remission, they will proceed to consolidation with an allograft. In patients who do not respond or do not go into remission after DA, you can escalate treatment to FLAG-IDA. CPX is also an intensive therapy and can be used in secondary AML or patients who have previously had cytotoxic therapy and their AML results from previous chemotherapy. So the factors affecting choice of consolidation treatment, it's not always clear which treatment option is best for consolidation. If the patient took many courses of chemotherapy to bring about a remission, then you might want to opt for a more intensive program and opt for an allograft. However, if the availability of a donor is limited, then you may bridge treatment with high-dose cytarabine consolidation. For older patients above the age of 60, if they are not fit for intensive chemotherapy, then you can use venetoclax azacitidine, and that's NICE approved since 2022 for patients not fit for intensive induction. Venetoclax is most effective in NPM1 mutated disease, FLT3 negative AML, but it has been approved for all cytogenetic groups. So some of the newer drugs on the horizon with FLT3 inhibitors, it targets tyrosine kinase with either IDTD mutation or TKI domain mutation. Midostaurin is first generation and it targets both, and it's used alongside DA in induction treatment. The other drugs listed here are second generation FLT3 TKIs with more potent specific action. Quizartinib has been used in relapsed refractory patients and allows some bridging to transplant. Gilteritinib is licensed also for relapsed disease. Liposomal preparations of daunorubicin and cytarabine is CPX351, and studies have shown that it improves overall survival, particularly in therapy-related MDS-related AML. CD33 is highly expressed on AML blasts and increasingly less so as myeloid cells differentiate. It's not expressed on CD34 positive pluripotent stem cells. CD33 is also found on hepatocytes, which means gemtuzumab has a risk of causing immuno-occlusive disease. So gemtuzumab targets CD33 on leukemic cells. It's given with DA for fit intensive treatment and first line only. It's used for favourable and intermediate cytogenetics, not adverse risk groups, and you can give up to 3 doses. The white cell count needs to be less than 30 because of tumor lysis, and the liver function needs to be normal. It does interact with an azole, so posaconazole, voriconazole, these antifungal treatments can start 5 days after the last dose. With midostaurin, which targets FLT3 mutations, it can be given continuously for 1 year as maintenance after induction therapy. It can cause nausea and prolonged QTC. Side effects of CPX is a rash and prolonged cytopenias. You can give it in treatment-related AML, previous CMML, or previous MDS. On patients who have karyotypic changes of MDS with -5q, -7q, -11, -12, -13, -17 deletions. Sigilteritinib is monotherapy for relapsed refractory FLT3 mutated AML. It can also cause prolonged QTC. IDH inhibitors like inacidinib and ivosidenib has shown some evidence in relapse disease but is not available in the UK as of yet. CAR T cells are being developed against CD123, which are present on more than 90% of blast cells and has been used to bridge to stem cell transplant. Again, it's not available in the UK yet. Thank you for watching. If there's any comments or corrections, please email me on blood.doc@gmail.com.